Good evening. Today is part 2 about renal and systemic vasculitis. Our focus today will be about treatment of ANCA-associated vasculitis according to KDIGO Guidelines 2021. This is our agenda. Of course, we talk about diagnosis in details in part 1, but to summarize, if we suspected kidney vasculitis, either by increase in serum urea and creatinine, proteinuria, hematuria, dysmorphic RBCs, normal complement. With this clinical presentation, of course, if there is multi-system affection, lung or upper airway affection manifestations, and there is we should order for serum ANCA, C ANCA and B ANCA. If we found them positive with the clinical presentation and there is rapidly progressive disease of rapidly progressive nephritis, of course we should start treatment without any delay, and biopsy can be done after starting treatment. The note is that we shouldn't delay starting treatment in highly suspicious cases to wait for the biopsy. If there is ANCA positive, start treatment. ANCA positive with clinical presentation and rapidly progressive disease, start treatment as soon as possible. But if the ANCA were negative, we should wait for biopsy. If it comes with a conclusive of ANCA-associated vasculitis or renal limited vasculitis, we can start treatment then. This is a summary for the treatment of ANCA-associated vasculitis. I put it here in the beginning to summarize and then to go for details. To start, we'll start by induction. For induction, we should give glucocorticoids with either cyclophosphamide or rituximab. So we should give the recommendations to give glucocorticoids with either cyclophosphamide or rituximab. In severe cases, in the form of serum creatinine more than 5.7, or if there is life-threatening organ affections or vital organ affection, we should consider adding plasmapheresis to these treatments. But if there is no organ-threatening involvement, which is not the case in most of the cases, we should consider giving mycophenolate mofetil. After control of the disease with this induction treatment, we should start maintenance therapy. The maintenance therapy, if we start by cyclophosphamide, we can switch to azathioprine with low-dose glucocorticoids, or if we start by rituximab, we should continue with rituximab without steroids. And then we should taper steroids, stop rituximab according, and then stop treatment as we going to discuss later. For induction, as I said, the recommendation is to give glucocorticoids in combination with either cyclophosphamide or rituximab, and the recommendation is 1B, very strong recommendation. Again, glucocorticoids with either cyclophosphamide or rituximab. In patients with markedly reduced or rapidly declined GFR in the form of serum creatinine more than 4 mg per deciliter, in this case, severe cases, cyclophosphamide and glucocorticoids are preferred. Cyclophosphamide will be preferred over rituximab. The data is limited for the use of rituximab in severe cases. In such severe cases, we can give rituximab and the cyclophosphamide can be considered, but the recommendation or the preference is for in such severe cases to give cyclophosphamide and glucocorticoids. When we should discontinue our immunosuppressive therapy, we should discontinue after 3 months if the patients remain on dialysis and don't have extrarenal manifestations, because we will gain no benefit. If the patient remain on dialysis for 3 months and don't have extrarenal manifestation, we should discontinue our immunosuppressive therapy. We'll discuss what about the choice for induction to choose between rituximab or cyclophosphamide. For cyclophosphamide, as I said, we should use it, or it is preferred in such severe cases when the serum creatinine is more than 4 milligram per deciliter or more than 354 micromole, or if the rituximab is not available or there is difficult to access for rituximab. And the rituximab is preferred in children and adolescents, in premenopausal women for the fertility issue with cyclophosphamide, in elderly population, in relapsing disease, or in patient with proteinase 3 ANCA positive. These are the preference for rituximab, and here we can use cyclophosphamide. Of course, the availability will be a major issue. What about if we use cyclophosphamide? When to use intravenous or oral cyclophosphamide? Oral cyclophosphamide is much cheap, so when the cost is a factor, we can use oral cyclophosphamide. Or if the access for infusion center or to give IV cyclophosphamide in a hospital is an issue, then we can use oral cyclophosphamide. But when to use an intravenous route? Intravenous when there is a higher cumulative dose, because as we know, the oral dose will give more cumulative dose. So if the patient had already a high cumulative dose or moderate cumulative dose, then we should give intravenous. If the patients had lower white blood cell count, so the preference for the intravenous route. Of course, we can give intravenous if there is access to intravenous or if the adherence may be an issue. If your patient will be not adherent for oral treatment, then to give a proper dose, we can give intravenous cyclophosphamide. What about the doses for the rituximab or cyclophosphamide? For oral cyclophosphamide, the dose will be 2 milligram per kg per day for 3 months. 2 milligram per kg for 3 months. If there is ongoing activity, you can reach a maximum of 6 months, but this will give a very high cumulative dose. The usual duration will be 3 months. But don't forget that we can reduce that dose with age. In patients with 60 years or more than 60 years of age, the dose will be 1.5 milligram per kg per day. In patients older than 70 years of age, the dose will be 1 milligram per kg. And if the GFR is less than 30 milli per minute, we should reduce the dose by 0.5 milligram per kg. But don't forget these modifications. It's very important. What about the intravenous cyclophosphamide? The dose for the intravenous cyclophosphamide is 15 milligram per kg at weeks 0, 2, 4, 7, 10, and 13. We can prolong the duration if there is still ongoing activity, but the dose is 15 milligram per kg at weeks, as we said, 0, 2, 4, 7, 10, and 13. Again, there is dose modification according to the age. If the patient is more than 60 years, should reduce the dose from 15 to 12.5 milligram per kg. More than 70 years of age, reduce the dose to 10 milligram per kg. And if the GFR is less than 30, we should reduce the dose by 2.5 milligram per kg. What about the rituximab dose? We have two regimens. Either we can give the 375 milligram per square meter per week for 4 weeks, for 4 doses, every week for 4 weeks, or we can give 1 gram at weeks 0 and week 2. So again, either we can give 375 weekly for 4 doses or 1 gram every 2 weeks for 2 doses. If we will use rituximab and IV cyclophosphamide, when we can use this regimen in severe cases, as we said, in severe cases, the preference for will be for the cyclophosphamide plus steroids, and we can use in some situations rituximab and IV cyclophosphamide. In these conditions, the doses will be for rituximab the same as we said here, 375 milligram per square meter weekly for 4 doses, and IV cyclophosphamide 15 milligram per kg at weeks 0 and 2. Or we can give the other regimen for rituximab 1 gram at week 0 and week 2, combined with IV cyclophosphamide 0.5 gram every 2 weeks for 6 weeks, as we know for the Eurolupus protocol. What about the MMF? The MMF is usually given in the dose of 2 gram per day in divided doses. 2 gram per day can be increased to 3 gram per day for if there is poor treatment response. A very important slide about the dose details about different agents. What about the steroid tapering? This is a suggested protocol for how to reduce the steroid dose, as in the Bexivaz trial, according to the body weight and the week. You can check it in details, also will be very helpful. What about the use of plasma exchange? As we said, plasma exchange will be used or can be considered if there is severe deterioration of kidney function when the serum creatinine is more than 5.7 milligram per deciliter or 500 micromole, requiring dialysis, or with rapidly increasing serum creatinine, and in patients with diffuse alveolar hemorrhage. Very important, you should know the indications of considering plasma exchange either in the clinical life or in the exams, either in the master or MD or European specialty examination. A very common question: when we use plasma exchange in the treatment of ANCA-associated vasculitis, these are the indications. Of course, we can add plasma exchange in patients with overlap syndrome with both positive ANCA and anti-GBM disease. In overlap syndrome, ANCA and anti-GBM, we should consider adding plasma exchange. We finished the induction treatment, and after control of the disease with induction treatment, what about the maintenance? In maintenance, as we said, we can use either rituximab alone, or azathioprine and low-dose glucocorticoids. So we have two choices, or rituximab alone or azathioprine plus low-dose steroids. Following cyclophosphamide induction, if we use cyclophosphamide for induction, we can use either the two different regimens. Either we can use azathioprine plus low-dose steroids, or we can use rituximab without steroids. Following rituximab induction, maintenance therapy should be given to almost all patients because the relapse is much more common. When we can use methotrexate for maintenance, can we use it? Yes, we can use methotrexate for maintenance therapy. We can use methotrexate for maintenance if we used methotrexate for induction, or for patients who were intolerant to azathioprine and MMF. So if we use methotrexate for induction, we can use methotrexate for maintenance, and we can use methotrexate for maintenance in patients who are intolerant to azathioprine and MMF, but not in GFR less than 60 milli per minute. Again, as we described in induction, how to choose between rituximab and cyclophosphamide. Again, here in maintenance, how to choose between rituximab and azathioprine. Rituximab will be preferred in relapsing disease, in patients with proteinase 3 positive, elderly population, if the steroid tapering is needed, especially in patients who are intolerant for steroids, or in patients with azathioprine allergy. And of course, we can use azathioprine if there is limited availability of rituximab, or in patients who were hepatitis B virus positive, or in patients with low immunoglobulin G. These are the criteria of how to choose between rituximab and azathioprine for maintenance therapy. What about the duration? For how long we should give either azathioprine or rituximab? When we use azathioprine plus low-dose steroid, the duration will be between 18 months and 4 years after induction of remission. So if we use azathioprine and low-dose steroid, the duration will be between 1.5 years to 4 years. But in rituximab, the duration will be 18 months. The duration will be 18 months. Again, as we said, there is no rule for the use of oral steroids with rituximab maintenance. If we use rituximab in maintenance, it will be used alone for 18 months. What about the doses? As we described in induction, we will talk in maintenance. What about the doses for maintenance agents? If we use rituximab, there are two different suggested protocols. The first protocol will be to give 500 milligram twice at completing remission, and then to give 500 milligram at months 6, 12, and 18. So to give 500 milligram twice at complete remission, and then to give 500 milligram at month 6, 12, and 18. Or to give 1 gram infusion after induction of treatment at induction of remission, and then to give 1 gram at months 4, 8, 12, and 16 after the first infusion. This is the second protocol. We can use either of them. What about azathioprine? The dose for azathioprine is, as we know, is 1.5 to 2 milligram per kg per day at complete remission until 1 year after diagnosis. So after completing remission and starting azathioprine, the starting dose will be 1.5 to 2 milligram per kg per day until, for how long? This dose for until 1 year after diagnosis, and then to decrease this dose by 25 milligram every 3 months. To decrease that dose by 25 milligram every 3 months. We can extend the duration, as we said, for azathioprine in maintenance, can extend it up to 4 years. If we decided to give it for 4 years, and the starting dose will be 1.5 to 2 milligram, as we said, we should continue it for not for 1 year, we should continue that dose for 1.5 to 2 years, and then to decrease that dose by 1 milligram per kg per day until 4 years. This is if we give for 18 to 24 months, and this is for if we decided to prolong the duration of giving azathioprine for maintenance. Of course, as we said, for azathioprine, we should give with azathioprine in maintenance low-dose steroids. Steroids should be continued at 5 to 7.5 milligram per day for 2 years, and then to reduce it slowly by 1 milligram every 2 months. MMF can be given in the dose of 2 grams per day at completing remission, and to continue it for 2 years if we give it in induction. What about the relapse? If the patient had a relapse, and we know how to diagnose a relapse by increasing kidney functions or by the increase in proteinuria or hematuria. If there is a relapse, we should give induction treatment. And we said for the induction, we should give steroids plus rituximab or cyclophosphamide. And in relapse, the rituximab is preferred over cyclophosphamide. So we should give induction treatment again in relapse, and it is preferred to be with rituximab plus steroids. This table summarizes the factors that increase the risk for relapse, also an important table. Who are at risk for relapse: patients who are diagnosed with granulomatosis with polyangiitis, protein A3 positive patients, lower serum creatinine, more extensive disease, and if the patient had at baseline ear, nose, and throat disease. Factors after diagnosis: history of a relapse before, or if the ANCA remained positive at the end of induction treatment, or if there is a rise in ANCA titer. What about treatment factors? If the cyclophosphamide exposure or cumulative dose is low, so this is a risk, or the immunosuppressive agents were withdrawn early, or steroids were withdrawn early. All of these factors will increase the risk of relapse. What about a refractory disease? Refractory disease, if there is no response for initial treatment, can be treated by increase in the steroid dose and by the addition of rituximab or cyclophosphamide. If we used cyclophosphamide, we should try rituximab, and if we used early rituximab, and then we can try cyclophosphamide. And of course, plasma exchange can be considered in such refractory cases. And in patients with diffuse alveolar bleeding, plasma exchange should be considered in addition to the initial induction regimen, either by steroids or cyclophosphamide or rituximab. So we can add plasma exchange in such refractory cases, or if there is alveolar bleeding. Regarding transplantation, we should delay transplantation until the patients are in complete clinical remission for more than 6 months. Delay transplantation. And another note is that the ANCA persistence, if the ANCA remained positive, we shouldn't delay transplantation. If the ANCA remained positive, we shouldn't delay transplantation. We decide according to the clinical remission, not on the ANCA or not on the ANCA titer. Again, this is our last slide. This is the summary. For induction, we can give steroids, or steroids is a must, plus cyclophosphamide or rituximab. If the condition were severe, we should consider adding plasmapheresis. And after control of the disease, we should start our maintenance therapy by either azacitidine plus low-dose steroids or rituximab. We continue rituximab for about 18 months, and azacitidine, the duration for maintenance will be between 18 months and 4 years. This lecture is according to the treatment of ANCA-associated vasculitis according to the KDIGO 2021 published last year. Thank you.